Hello, welcome everybody. Thank you for those who are joining. We're just going to give everyone, another minute or so to join the session, and then we'll get started. Hello, good afternoon, everyone. Thank you for joining. I see a lot of new joiners. We have some people still entering the call, so we're just going to give, another 30 seconds, and then we'll start the call. We'll start the session. Okay, I think we're going to go ahead and get started. So first of all, let me say good afternoon, everyone, and welcome. Thank you all for being here today. We have a very exciting session ahead focused on PGT A Plus and the rapidly evolving landscape of reproductive genetics. My name is Diana Alameddin. I'm a senior genetic counselor with VitraLife Group based here in the UAE, and I will be moderating the session today. To give you a very brief background on myself, I've been practicing in the field of genetic counseling for more than 10 years across multiple subspecialties. In 2022, I transitioned into the field of reproductive genetics with a particular focus on pre-implantation genetic testing and reproductive genetic counseling. And since then, I've been working closely with fertility specialists, embryologists, and patients to support complex reproductive genetic decision making. Before we begin, I just want to discuss a few housekeeping items. We will be having time at the end of the session for your questions and discussion. So please feel free to send your questions throughout the session using the chat box, and we will do our best to address as many of them as possible during the Q&A section. If we do not get to them all, please be sure that we will address them after the session. Today, we're fortunate to be joined by an outstanding panel of experts, each bringing deep clinical, scientific, and laboratory expertise in reproductive genetics and assisted reproduction. First, we have Dr. Laura Girardi, who earned her PhD in molecular medicine from Padua University and currently serves as head of scientific support department at iGenomics. Dr. Girardi has been working in the field of reproductive genetics since 2015 and has extensive experience in PGT diagnostic services, research and development, and innovative technologies related specifically to aneuploidy and mosaicism and trophectoderm biopsies. We're also joined by Mrs. Maria Escriba, senior clinical embryologist at Equipo Juano Crespo in Valencia, who earned her master's in biotechnology of human-assisted reproduction from IVI Valencia. Maria's work focuses on pre-implantation genetic testing and embryo quality with the goal of continuously improving clinical outcomes in assisted reproduction, and her research has been presented at major international meetings including ESHRI, ASRM, and PGT-IS. So together, our speakers bring years of international experience in research, clinical practice, and patient care. And I'm really looking forward to the perspectives and discussions that they will be sharing with us today. Without further ado, I will hand the floor over to Laura to present her presentation.
Thank you. Thank you very much, Diane, and thanks everyone for joining. This is my presentation. I will talk about mainly the benefits of an advanced SNP-based technology. So let's start with a little bit of background. I hope you are familiar with the concept of pre-implantation genetic testing for aneuploidies. This is usually considered as an embryo selection tool. Basically, we are able to get the copy number information from each embryo and distinguish if the embryo is diploid, so correct number of chromosomes, or if the embryo is aneuploid, so presence of extra or missing chromosomes. I want to remark the fact that the main aim of PGTA is, and the main benefit for your patients is always deselecting this type of uniform meiotically derived aneuploidies, as they can result in implantation failure, miscarriages, or even the birth of a child with a fetal aneuploidies. How do we detect these aneuploidies in pre-implantation genetic testing? At iGenomics, we use a combination of next-generation sequencing and artificial intelligence to analyze the genomic data of our IVF embryos. As you can see here, we have two main advantages: a high level of automatization to ensure reproducibility and high quality of the results, and also we use a proprietary diagnostic algorithm that is able to reduce the subjectivity when evaluating the profiles. I also want to stress the importance of validation of the technology and the platform. Indeed, the level of technical and analytical and preclinical validation of our platform is supported by numerous evidence, where the confirmation for whole chromosome uniform meiotically derived aneuploidies is higher than 99%. Well, despite this, we know that there are some limitations in NGS-based technology which rely only on copy number analysis, because we saw that they are extremely accurate in detecting whole chromosome aneuploidies, but actually they cannot distinguish if there is a variation in the entire set of chromosomes. So due to a normalization procedure during the sequencing run, if all chromosomes are deleted or duplicated and they are compared between each other, they do not result as different. This means that some configurations like ploidy abnormality will pass undetected. In this example, you have a profile which will be called as euploid XX for PGTA, but actually without an additional layer of information, we will not be able to say if it is a diploid, a haploid, a triploid profile, or even a female embryo contaminated with an external female DNA. So how to improve our approach to better classify these profiles? Today, next generation sequencing brings new possibility to overcome basic technical limitations, and this is possible thanks to the incorporation of SNP genotyping information in the same PGTA workflow. This is exactly where we decided to focus and invest to improve our approach. So we designed and validated a custom panel composed of 350 SNPs, single nucleotide polymorphism markers, and this is coupled with a bioinformatic pipeline that is able to read this complex information, because SNP markers goes deep at the DNA sequence level. So actually what we want to interrogate is the B allele frequency of the SNP that we are including in the platform. And this is very relevant to get additional information in our workflow. Then before incorporating this approach in the clinical practice, obviously, we performed an extensive preclinical validation of our pipeline, and we used both cell lines with known ploidy status, but most importantly, rebiopsies from the embryo, known as diploid, triploid, or haploid. And very recently, we also had the opportunity to make some improvements in our algorithm of analysis, and we also published, of course, this information and the accuracy that we reached. Now, I want to focus more on one of these new elements that we can get from this SNP analysis, that is obtaining the ploidy level information. So basically, by incorporating the SNP analysis and interrogating a number of markers across the genome, we can now potentially distinguish if the embryo is diploid, meaning two sets of chromosomes, one from the sperm and one from the oocyte, or if we have this type of configuration where we have complete loss of a heterozygosity, so we miss a contribution from one genome and the embryo is haploid, or if we have this profile where the SNP show an additional genotype present, which is compatible with an additional chromosome set, so a triploid profile. And just for you to know, these profiles were not possible to be derived before with standard next generation sequencing. So these profiles would have passed undetected. From a diagnostic consideration, is important to notice that both haploidy and triploidy are compatible with pre-implantation embryonic development. But while haploidy has never been observed in pre-implantation development or in the pregnancy, triploidy can be found in up to 10% of chromosomally abnormal spontaneous miscarriages and is usually not compatible with developmental to term. So very important to have the opportunity to detect and deselect these abnormalities. Now, after more or less 1 year of experience, we have been able to publish our clinical experience in the application of diploidy test. This is the paper from 2024 and was particularly useful, especially to produce data regarding the correlation between the morphological pronuclear status and the genetically determined ploidy status. So here I want to introduce the concept of molecular fertilization check, which is provided by the addition of these SNPs in the protocol and thanks to the ploidy feature, which can actually improve the standard morphological pronuclear check. So as you can see in the study design, we tested a cohort of apparently normally fertilized zygotes, but we've also characterized a great number of embryos showing atypical pronuclear patterns at fertilization check. So we provided additional useful information to guide potentially the clinical use of these embryos. Let me now guide you through these results. So firstly, looking at embryos with normal fertilization, so 2PN at fertilization check, using our PGT assay empowered by SNP genotyping information, we identified 1% of total embryos being affected by ploidy abnormalities, with the most frequently abnormality, triploid, accounting for around 0.8%. However, it's also important to highlight that quite recently, we, but also other groups, found a clear trend in increasing triploidy with increasing female age. Up to 4.5% of total embryos can be affected by triploidy if we have female age above 40. So it is clearly a benefit having the information coming from the genome-wide ploidy status of the embryo to be able to further refine our embryo selection process by identifying and deselecting these abnormal ploidy configurations. Then another application is related to testing embryos showing atypical pronuclear patterns at fertilization check. As you probably know, these embryos as routine practice are discarding due to the high risk of an abnormal ploidy constitution. So we apply the same ploidy test in this data set of 380 zygotes with 0, 1, or more than 2PN. And what we found is that it's clear that there is no perfect association between the pronuclear status, so what the embryologist sees, and the ploidy configuration determined with a genetic platform capable of identifying these abnormalities. So with our ploidy analysis, potentially we can now identify additional candidates for transfer, and in particular in this study, additional 230 euploid and diploid embryos have been saved and potentially made available for transfer and would have been otherwise discarded. For those people using time-lapse is also interesting as an aspect, the impact of the type of observation. So in this exploratory study, we also isolated a small data set of 50 embryos where pronuclear visualization was assisted by time-lapse monitoring. And what we found is that there is an overall increase in the predictivity of the pronuclear status toward the corresponding abnormal ploidy status, means more haploids from 1PN and more triploids from 3PN, which is obviously provided by a more precise pronuclear classification. As a consequence, as you can see here, there is a decrease in the proportion of diploid embryos from these abnormally fertilized embryos, which is now confined to 1PN and 2.1PN embryos only. Now, having SNP genotyping information can provide also additional benefits when testing embryos for PGTA, and particularly having qualitative information regarding our embryos that we call sample quality control, sample QC, or quality control parameters. One is contamination detection, and the other is called cohort check. Well, SNP genotyping can actually help in detecting contamination, and adding this feature is quite relevant aspect in our routine practice, as contamination can mask the true chromosomal status of the testing embryos. So this can lead to erroneous results and potential misdiagnosis. Here, I can show you an example of a profile of a low mosaic monosomy 21 with contamination. So this means that was seen as an intermediate profile, but with contamination. The clinic decided to go ahead with rebiopsy, and the result came back as full monosomy 21, so not more an intermediate profile. So for sure, contamination can have an impact in the mosaicis aneuploidy diagnosis, but very importantly, now we can see with our pipeline if there is more than one genome in the samples that you are sending. after collecting, again, global experience and global data, we can now say that around 0.5% of all the two-factor biopsies can be contaminated. The other interesting parameter is cohort check analysis. So SNP analysis can help in check if there is genetic relatedness between the embryos in the cohort. So in other words, if all embryos originate from the same sperm and the same egg source. And we expect so to have a sibling relationship between each other, and SNP can confirm this relationship and provide more reassurance. The other benefit is detecting eventual mismatches. But I want to reassure that the rate of inconsistent cohort check or mismatches is actually very, very low. But at least we have an additional layer of information that will be reported in the report that will provide more reassurance to your patients, telling that all the embryos are related. Finally, I want to close my presentation showing the benefit of the comprehensive SNP analysis. So adding SNP information to our PGT A Plus can give an additional overall improvement in the PGT-A accuracy. So this is another data set of more than 2,000 embryos, almost 3,000. We detected in this data set 1.4% of triploidy and diploidy. And the question here is how these embryos would have been reported if only PGT-A without SNP analysis would have been applied. A great proportion would have been reported as mosaic, so intermediate copy number for autosomes, some as intermediate copy number for sex chromosomes, and in some cases even as euploid for PGT-A without SNP analysis. So for sure, this addition is going to improve the accuracy in mosaicism and aneuploid diagnosis, and improving overall the accuracy of PGT-A identifying triploidy and haploidy in those embryos that otherwise would have been diagnosed as euploid. So in conclusion, this is our new approach, PGT A Plus with all the features included. And this we can see, here you can see the multiple benefits from the application of this comprehensive analysis, including reducing the risk of miscarriages due to previously undetected abnormalities, especially triploidy, increasing the identification of viable euploid embryos available for transfer. This will come from the test of embryos coming from abnormal fertilization, enhancing the accuracy by reducing the risk of misdiagnosis due to undetected contamination. We can provide definitive confirmation that all embryos within the same patient cohort are genetically related, so great reassurance and reducing mismatches, and overall ensuring enhanced efficiency and quality control in the laboratory procedures conducted within your IVF lab, and providing greater reassurance to you and your patients. So I want to thank for your attention. I will leave now the floor to Maria, and I will be back for the Q&A session. Thank you.
Thank you, Laura. Hello, everybody. First of all, I would like to thank Vitrolife for inviting me to share our results with all of you today here. I'm going to talk about PGT A Plus from the perspective of a clinical embryologist and how it improves our clinical routine in an IVF lab. Okay, as we know, in IVF lab, fertilization is usually confirmed around 16, 17 hours after conventional IVF or ICSI. Okay. And when we know that the egg is fertilized when we observe 2 nuclei at the extrusion of the second polar body. This is what we call a 2PN embryo, but sometimes we observe only 1PN or 3PN, indicating an abnormal or atypical, how we like to say, fertilization of the oocyte. These embryos were or are often discarded due to suspected risk of being abnormal. So the question is, do all cycles with atypical fertilization have an actual diploid or haploid chromosomal complement? In 2017, Capalvo et al. Published this study, and they proved that viable embryos could be rescued from a pool of atypical embryos. The problem was at that time the technology was suitable for researcher purposes, but not for a clinical routine. But few years ago, Igenomix launched this Smart PGT Plus, which is a 4-in-1 PGT test with several advantages, as Laura has already explained. Okay, I'm going to focus on the early detection, as this allow us to make the biopsy and to get the analysis, the results of 1 p.m., 2 p.m., and 3 p.m. embryos, because they classify them as haploid, diploid, triploid according to the number of chromosome sets. So in a simple way, because another very useful thing, especially for an embryologist and for a clinic, is that this is very easy to use, because you don't have to change your routine about the biopsy or the tuning. It's exactly the same, and we don't need parental samples. So in a simple way, we are able to biopsy and try to rescue embryos that otherwise they would have been discarded. So knowing that some embryos could be rescued, and now having the technology, we started a study, and we started with the first study was about 3 p.m. embryos. We wanted to compare both types of 3 p.m.s, because as you may know, there are two types of 3 p.m.s. One has all the free nuclei are similar in size, and the other group has two similar in size, and the third one is smaller. We wanted to compare them to see if they behave in a similar way or different. And the most important, we wanted to quantify how many embryos could be rescued for the patients to see if it's a real benefit for them, if it's worth it to do or not. We have been working on this since 2023, so now we have gathered a good number of data. This is the design of our study. It's a prospective observational study that gathers data of 603 PPN embryos from 557 cycles of 524 patients. It's in our clinic in Equipo Juana Crespo, that is located in Valencia, in Spain. And since June 2023, we have the analysis and we have the results of 228 biopsy blastocysts using Smart PGT A Plus. During that time, our incidence was 2.09% of this type of them. So the first thing we did was to define both groups. The first group is the micro 3pm, or the 2.0, commonly known as 2.1 ppms. In this group, the diameter of the smallest nucleus is less than 70% of the diameter of the largest one. This may be difficult to identify, okay, especially in granular or dark eggs. According to our experience, it's much easier to spot them using time-lapse, using embryoscope, because sometimes it's quite difficult. Another benefit of using embryoscope is that sometimes, like in this video, at the time of the fertilization check, it's not possible to see this third PM because it's hiding behind, or sometimes it's blurred and you can't see it. But then if you have the video, the next day on day 2 or whenever you check the embryo, you will eventually check it and you will see this extra PM, so you can call the patient, tell what has happened, and advise her in the best way. Another utility is that sometimes we see a two very clear PM and then we see something else, like in these pictures. But we are not sure if it's a small PM, a buckle, or something. If we have a video, it's much easier to recognize it, because if it's a PM, all will move, all 3 PMs will move in a synchronized way, and they will all fade at the same time. If it's a buckle, it won't behave like that. The second group are what we call same size 3 PMs, or the 3 PMs. In this group, the diameter of the smallest nucleus is more than 70% of the diameter of the largest one. These are very clear, very easy to identify. So these are our data. In the 2.1 group, we have 325 embryos. Out of these, 120 reached the quietly blastocyst stage. Out of these 120, 111 were informative for ploidy and reploid analysis, resulting in 101 diploid ones and 10 triploid ones. Out of these 111, 23 were euploid, 5 were mosaic, and 83 were aneuploid, resulting in 27 transferable embryos, 22 diploid euploid and 5 diploid mosaic. On the other group, the same size 3 PM, we have 281 embryos, 108 reached the quietly blastocyst stage, 91 were informative, resulting in only 4 diploid and 87 triploid ones. Out of these 91, 36 were euploid and 55 were aneuploid. We were lucky, and one of these diploid ones was euploid, so we have one transferable embryo. We're going to compare both groups' outcomes. First thing is blastocyst formation. Both groups are very similar. It's 36.9% in the 2.1 group versus 38.4% in the 3PN group. There are not significant difference between them, but both of them are significant different, have significant difference between their siblings 2PN embryos on the same cycles. So blastocyst formation for a 3PN embryo in both groups is lower than expected for a 2PN embryo. Talking about diploidy, this is the most striking part because there's a huge difference between them. In the 2.1 group, 91% of them were diploid, almost all of them, versus only 4.4% in the same size group. So this is what will make the difference between them. Talking about diploidy rates, we are fully aware that 202 samples may not be enough to draw definitive conclusions from a PGT program, especially due to the heterogeneous data from the age of our patient. But what we see is that there's not significant difference between the aneuploidy rates between the same size 3PN groups and the 2PN groups. However, the aneuploidy rate in the 2.1 group is higher than the 2PN group. We think that this is partially due to the own nature, to the special nature of this type of embryos. And as a result, we have a 24.3% of embryos available for transfer, rescued embryos in the group of 2.1 embryos of the biopsy one versus only 1.1% in the same size 3PN. So 24.3%, almost a quarter of all biopsied 2.1 embryos are transferable, and that's a really good number. So yes, it is worth it to analyze them. Due to the low number of embryos transferred today, it is still very early to draw definitive conclusions. But what we see is that the implantation rate of these embryos is not inferior by nature, because we have transferred only 4 embryos in 4 transfers, 4 2.1 embryos. 2 were transferred in a set, in a single embryo transfer, and both patients are pregnant. They are in the 5th and the 6th month of pregnancy, and they are very happy, and we are very happy because those were their last embryos. So yes, that makes a difference for this patient. Now I'll talk very briefly about the 1PN embryos. Since last year, on June, we started a new project about these embryos. These embryos show only 1PN. And if they result diploid as a result, we think that this happens because it's a fusion of the PN membranes. And if they result haploid, it's because there's a lack of the paternal complex. These are our results. We have seen during this period 3.6% of incidence, which is a high incidence, resulting in 258 1PN zygotes since June last year, and it's still ongoing. 38 have reached blastocyst stage, making only 14.7% of blastocyst rate, which is a low blastocyst rate, especially compared with almost 60% that have our 2PN embryos. So yes, it is a low blastocyst rate, but 20 of them were diploid and 17 were haploid, so resulting in 54% of the diploid rate of these embryos. We have 12 transferable embryos, 11 are diploid, and 1 is diploid and low with no shape. So as a result, 32.4% of the biopsy 1PN, almost a third of them, can be transferred. A third is an even better number to rescue. So yes, it is worth to analyze this type of embryos. I'm going to talk very quick about this type of embryos, as Laura has already explained. But PGT Plus is not only suitable for atypical fertilized embryos, it is also for a 2PN. This is a study of Dr. Lorena Rodrigo last year in PGD, showing that the incidence of gathered data around the world, 1.4% of them of the blastocysts derived from normal fertilization, 2PN, were abnormal, were haploid or triploid. Triploid was most common, and that's even worse because they could derive from a molar pregnancy. This is another study saying more or less the same, but with a bigger number. And they want to highlight that with the maternal age effect, increasing the age of the mother, is increasing the risk of having a triploid embryo. And I wanted to say that we have seen this in our lab from a clinical perspective. Sometimes it's not very common, but sometimes we receive a report from a 2PN embryo that it's triploid. And we go to check the embryo because all of them are in embryoscope. And when we check the embryos are very clearly 2PN. So there's no doubt that they were 2PN, but still they result in triploid. So this happens, and with this PGT A Plus, we can avoid that. Summarizing, just to have a brief, quick with the site, is like we are rescuing almost a quarter of the 2.1 embryos and almost a third of the 1PN embryos. So answering our question, yes, it is worth it to analyze these embryos because they are a real benefit for our patients. Just quick conclusions is like about 3PNs is that it is very important to differentiate both types of 3PNs, as this will help us to know the potential of the embryo. Most of the 2.1s are diploid, so it is worth to analyze them. And very important is like, despite most of them are diploid, the remaining 9%, which is not that low, of the 2.1 embryos are still truly triploid, so we cannot transfer them without a previous analysis, as they could result in a triple pregnancy and a molar pregnancy. For 1PNs, it's like they have a low blastocyst rate, but then more or less half of them are diploid, and a third are transferable, so it's worth to biopsy them. And for 2PN, it's like PGT Plus allow us to detect the triploid and haploid even on this type of embryos when we think that there's nothing happened to them. And we can avoid negative and some miscarriages. And thank you very much. I will leave you with Diane.
Thank you. Thank you, Maria. I hope everyone can hear me. Thank you, Maria. Thank you, Laura, for your excellent presentations. Before we open that up for questions, I would just like to give you, present a few slides on counseling considerations on PGT A Plus. Okay. So this is just, firstly, I would like to present a case and where we can really see the impact of PGT A Plus. So this is an example where euploid maybe isn't the full story. This is a 42-year-old female who presented with secondary infertility. She has one son who was conceived naturally in 2022, and then she conceived naturally twice after that in 2024 and 2025. But unfortunately, both times pregnancies resulted in miscarriage. So she elected to go for IVF with PGT-A. And fortunately, in her first cycle of IVF, she had a single embryo that was found to be euploid on trophectoderm day 5 biopsy and was ultimately transferred. However, unfortunately, around 6 weeks of gestation, she had a miscarriage. And so they managed to get a sample of the POC, the product of conception, and this confirmed, in fact, a triploid female profile. And so I think this just highlights, the theoretical and information that has been presented by both Laura and Maria, that certainly, these cases do exist. We do see them, and this is, the true added value of PGT A Plus here, and would be in detecting the polyploidy. The point that I would like to additionally highlight is the goal with this testing isn't so much to find more abnormalities or overscreen these patients, which certainly I can understand, is a concern. It's more to avoid acting on a result that may not be fully representative. It was very challenging for the patient herself going through this after having, transferred a euploid embryo and having the reassurance of a euploid embryo. I do just also want to give you, sample reports. So these will look very similar to the reports that you're already familiar with for PGT-A, and just highlight a few sample results that you may receive and how, again, the counseling may be impacted in these specific cases. As Laura highlighted in her presentation, PGT A Plus can allow us to have a more accurate diagnosis of true mosaic results, as is the case with this sample. So we have a low mosaic trisomy 20, which with ploidy testing has been confirmed to be diploid. Generally, the recommendation that we give to patients with low mosaic results is that overall they can be considered for transfer and have a very similar reproductive success rate with euploid embryos. But when confirming that it's a true diploid embryo, we can be very confident in the recommendations that we're giving that this is really a true mosaic embryo that we are discussing and transferring. And finally, just to highlight one more point in terms of counseling considerations, again with low mosaic results. So if you remember the example that Dr. Laura gave regarding the embryo that was initially resulted as a low mosaic trisomy 21, but with contamination on rebiopsy was confirmed to be a full trisomy 21. This is a very similar example. So here we have trisomy 13, but in which we have detected contamination in the embryo. I think you can appreciate the difference in counseling that you would do for a low mosaic trisomy 13 versus a full trisomy 13. And here, the idea with these embryos is that what we understand to be the case is the contamination is actually masking a full aneuploidy. So this, again, it gives us greater reassurance when we are transferring or making recommendations to patients in that if we have a low mosaic result, we're confident that it is a low mosaic result. So for this embryo, the recommendation would be not to transfer because most likely there's an underlying complete aneuploidy being masked by contamination, which is showing the result as a low mosaic trisomy 13. So with this, I will move on to the questions and question and answer section, and we would love to hear from you all and have a discussion. I do see that we have started receiving some questions, so I will go through those. One of the questions that we received from our attendees is, do we have any cases with the only euploid diploid embryo was atypically fertilized? So I'll leave this to either Laura or Maria based on your experience.
Maria, do you want to take it? And then
like one of these ladies that I say that she's pregnant, that was the case. Was the only embryo she had that was diploid was this one, was a 2.1 embryo, and she's pregnant and she's really happy. It's on her 6th month of pregnancy, and so far it's going great, everything.
Okay. We have another question from one of our attendees. If the 3PN embryos tested by normal PGT-A as regular, would the results come back as normal or abnormal if the 3PN embryos was tested normal as PGT-A?
I can take it. That's a good point. So if only PGT-A is applied and the embryo is euploid, will come back as euploid. If there are ploidy abnormalities, which are, for example, masking an aneuploidy, and PGT-A plus is not applied, the embryo maybe will come back as mosaic, for example. So depending if the ploidy level is normal or abnormal, we can have an impact for sure in the classification that we give for PGT-A. So finally, I would say that if you have a 3PN embryo, and according also to the data that Maria was showing, maybe is even not worth to test them because the probability of having a triploidy is really high. And I see that this is also in line with the latest recommendation that we have from the Istanbul consensus, for example. But in any case, deployed status is going to fact for sure in the PGTA only result.
Yes, but in our results we have many of them that are still triploid or even haploid, and they are still euploid. So only with PGT we will think that they were protocol transfer, but they are not.
Thank you both. One more question that we have is, so from another one of our attendees, how promising can whole genome sequencing be compared to next generation sequencing in the case of PGT A Plus?
That's another cool point. So whole genome sequencing for sure is going to give us more information. At the moment, what we are giving is sequencing based on, a low pass genome sequencing, so no whole genome sequencing. And in parallel, we have a targeted protocol for seeing these SNPs and derive ploid information. With whole genome sequencing, we will have, of course, additional information. We will be able to look at aneuploidies, ploidy abnormalities. We will be able to see even point mutations, de novo point mutation, and all the other range of de novo ploidy abnormalities. So for sure, it's very promising technology. I would say that we need proper validation before incorporating into the clinical practice, because the first publication that we have didn't show 100% of accuracy. Is not possible, obviously, but the accuracy was not as good as the actual platform. So very important validation, preclinical validation before moving into new approaches.
Thank you, Laura. Is there a difference between IVF and ICSI, 1PN, in terms of blast development and biparental diploidy?
In our case, all those results are from ICSI because we wanted to mix both types. A 1PN after conventional IVF is different because they could be, if they're not, you can see the eggs because you have to strip them before the fertilization. And sometimes there's a desynchronization of the PNs. So most of them are diploid, that's what it's believed, but you can see only one. So conventional IVF is different from ICSI from this point of view. So we have considered only ICSI results for this study. But I think it's in order to apply for the PGT Plus is the same. You can use it. There's no problem at all.
Yeah, I agree. There will be for sure some differences, but both in our study, which is similar to the one Maria presented, the majority of cycles were from ICSI as a fertilization method. So we didn't have enough sample size to be able to compare regular IVF with ICSI, and this is more or less the same in the literature. So this is a good point where we need more data, and I hope in the future we'll have more data also from our side to be able to support the clinics in the decision of using these embryos, also depending on the fertilization method.
Thank you. We do have one more question. So first of all, thank you for the presentation. Will iGenomics do PGT A Plus from the beginning for all biopsies or only for normal embryos from PGT A?
In our case,
yeah, please, Marianne.
In our case, we started like in 2023 only for this type of embryos because it was for a study and was in the, like on a routine, on a clinical routine. But then from the October, I think 2024, if I'm correct, we have changed to PET Plus for all patients. It's exactly the same from the point of view of our embryologist for the biopsy, tubing, everything. We're receiving the results in the same time. And we have the extra information about the cohort, contamination, more specifically for mosaic, and this thing that we have talked about, that sometimes they are 2 p.m. and we have a cheap rate result for upload.
Yeah, and for sure, PGT A Plus is applied on all the embryos that we receive if PGT A Plus is requested. So there is no distinction between euploid and aneuploid. The approach is applied on all the embryos to get the most benefit and to be able to classify properly all the profiles that we have on top of PGT-A.
Thank you both. I do have one more question. So, can you tell us, please, do you need any positive control for PGT A Plus cases, or do we need to send any additional samples when running PGT A Plus?
Yeah, thanks, Diane, for asking. There is no need to add extra samples to the PGT A Plus analysis. So we are going to analyze and process exclusively the same biopsy that you are sending for PGT-A. So from the same sample, we will be able to derive all the additional elements without adding parental DNA or any other sort of positive or negative control.
So there are no differences at all between PGT-A and PGT Plus from the point of view from the lab. Everything is the same. Yeah.
Perfect. Thank you. Firstly, I would like to thank you, Laura and Maria, for the excellent presentations. I want to thank our attendees for your time. For the valuable discussion. It's been a pleasure doing this today. If you have any additional questions, of course, please do reach out to your representatives in the area, and we are more than happy to answer any additional questions that you may have later on.
Thank you, Diane. Thanks for the audience for coming and for attending, and feel free to reach out.
Thank you, Diane. Thank you for inviting me to share our results. I'm very happy to be here with you.